We're honored to be joined by three clinicians, two from Ophelia. We have Dr. Adam BISAGA and Dr. Erica Lyon. And then we also, for Brave, have Dr. Amit Parikh. Sorry, I'm always tricky. Sorry for that, Amit. They will, over the next 30, 45 minutes, they will walk us through the real world care models with patients who are struggling with opiate use disorder and talk about how our partnership can work in practice and why integrating mental health and MAT is essential for recovery. After their brief presentations, we'll open it up to your questions and we're going to ask you some questions along the way. So keep an eye out on our chat. And without further ado, we'll dive in.
Hey everybody, thanks for that intro, Ashley. I'm really excited to talk with y'all a little bit about first just who we are at Brave Health, and then a little bit about the partnership that we've struck up together and how we're going to really help manage um, patients who are struggling with substance use disorders. And so first, just talking about Brave Health in general, we are a fully virtual um, mental health provider. We provide outpatient levels of care for patients who need it. We provide care for patients, whether it's their first time needing care, it's the first time they've ever reached out for something like therapy. Also, we provide care for patients who have been struggling with their mental health for years and maybe have more complex symptoms. And so, really, across that spectrum, we're able to help support you wherever you are in your journey. And we make it easy to do that. And that's kind of what makes Brave Health a little bit different. And so, the types of services we provide at Brave include psychiatry services. So that's like medication management. Now, sometimes when you're struggling with things like anxiety, depression, substance use, there's an indication to use a medicine to help support you in that recovery journey. And our psychiatric clinicians can help ensure that if there is an indication that you're going to get started on the right medicine and then monitor it on an ongoing basis to ensure that it's safe and that we're getting the positive outcomes we're looking for. Now, of course, we just don't do psychiatry services. We also do therapy services, and we offer a host of different types of therapy services, including individual therapy, group therapy, and family and couples counseling. And we combine all of these different modalities of therapy and psychiatry together to provide a really holistic solution and care model so that we're able to get the patient exactly what they need in the moment they need it. Now, of course, we know that a lot of our patients also have providers that they may be seeing in the community. Maybe they already have someone providing them medications, or maybe they already have a therapist in the community, but they need something from us that they don't have in their community. What we're going to do is we're going to make sure that we coordinate care with all of those other providers because we know in healthcare, silos just lead to poor outcomes. When we're not communicating as that patient's healthcare team, we're not doing what's best for the patient. And so it's really important for us to ensure that we let others know what's going on so that we can always be moving together in the same direction. And so if we hop to the next slide, um, one of the things that is really important to us at Brave is making it really easy to access care. We know that every friction point there is, whether that's having to download an app, having to remember a username, password, login, every friction point there is leads to one more person being like, I give up. I'm not doing this. I'm already struggling. I'm not going to go through with this in that vulnerable moment. And so we purposely make our telehealth platform and solution really simple to use. It primarily happens over text messages or emails. They get sent links directly when it's time for their visit. They click the link and they're off to the races without having to remember those types of things. Now, we're able to support people across that age and acuity spectrum, like I was mentioning. So we see patients who are 13 and above, and we work with patients who are just coming right out of the hospital. So patients who are just in more acute levels of care, and we ensure that they're getting those visits very quickly. Now you can see we treat a host of conditions. Of course, this isn't a comprehensive list, but it's a broad list, which is the reason we show it here, to say whether it's someone who has complex trauma-related symptoms or someone who may be struggling with an adjustment reaction for the first time in their life, we're going to be able to help get them the care they need. Now, one of the most common things that we work on is patients with co-occurring substance use disorders with also having mental health disorders like depression or anxiety. And that's particularly the partnership that we're going to talk about today comes into play, where we're really going to make sure the patients are getting the best support they need by combining the specialties that both our companies have. And then finally, the last thing here at the bottom is that we have a host of clinical pathways. And the reason we throw this out on this slide is to make sure that y'all know that we think about populations and try to think through how each population needs to be supported in their own individualized way. That's why we know the types of care and the screening tools that we're using for pregnant patients is different than adolescents, which may be slightly different for someone struggling with a substance use disorder. And so we really think through what's the best way to support this population and how should we develop a care model for that. And so if we hop to this next slide, we really believe that recovery from your use disorder starts with the right supports, right? And so that's a combination of therapy, psychiatry, peer support, and medication-assisted treatment to ensure that we're doing all of the things and we're tackling all of the possibilities of reasons that getting you to recovery may be hard. And so we build this supportive ecosystem around you. And so if we go to this next slide, what does this actually look like, right? So you've heard me talk a little bit about all the services that we have, but one of those pathways, of course, is this supporting recovery pathway, which is what we call our pathway for patients who have a substance use disorder. And so how do we approach this? Well, we're going to start off by doing a comprehensive evaluation to understand the needs that person has. We're then going to put together a system of care, whether that's therapy, peer support, psychiatry services to help support them. Now, sometimes we may identify that there are things that this patient needs that we aren't able to do at Brave. One of those things is medication-assisted treatment, which are things like methadone or buprenorphine for patients who are struggling with their opioid use. And so it's with partnerships like Ophelia where we're able to get those patients the care they need, which may be getting that medication-assisted treatment support, while we then help manage the therapy and help manage their medications for bipolar disorder, for example. And so it's really that combination and collaborative approach that's ensuring that we're targeting both things at the same time. Because sometimes we like to separate out mental health from substance use, but we all know it's one in and of the same, right? They're both so interrelated and we can't treat one without treating the other. And so if we go to this next slide, um, you know, part of that recovery is, we really believe a core foundation of it is through individual therapy, right? Our individual therapists are going to use a host of different techniques from cognitive behavioral therapy to motivational interviewing and skills that you may find in dialectical behavioral therapy to help support that patient's journey to recovery. They're going to help them identify, what are the thought patterns, what are the triggers they have that may be making it difficult for them to get to their goals of recovery. They're going to help work with them to understand their anxiety and depression, give them the skills, tools, and techniques to help manage their emotions and process the things that they've gone through in their life that may have impacted them, such as large traumas. And it's through that trauma-informed care, understanding where they're coming from and giving them the tools to help support themselves, that then they can build that strength and that resilience to to be able to get to the recovery place they want to be at. And so if we go to that next slide, like I was mentioning, we also have psychiatry services, which are sometimes called medication management. And it's in these services that we're able to help prescribe medications when indicated to help treat whatever that condition is that they may have, whether that is their depression, anxiety, bipolar disorder that may be impacting their substance use, for example. And we, as I was talking about, we know how interrelated these are. And if we don't treat it all together, their likelihood of getting to a positive outcome is much, much less, which is why it's so important that we're working together to have this collaborative approach and ensuring that the patients can get all the care they need together. And so our team will then work closely with their outside team and to make sure that we're all moving in that same direction. And so the the final thing that I haven't spent as much time about talking about, which I think is really powerful, is also our peer support and group recoveries, right? We know that sometimes it can feel isolating when you're struggling, and it can feel like you're the only one going through this. Peer support and group work is where you get a community. You realize you're not alone, maybe for the first time. And that can be powerful, especially as you get to see people who are in varying stages of their own recovery. It can start to give you hope when you feel like you don't have any, that things can and will get better by seeing someone who maybe was successful in their first attempt at recovery. And so if we hop to the next slide, um, one of the things that we're really proud of here at Brave is the importance and the level of effort we put into our suicide prevention program. We were one of the first virtual providers to implement a zero suicide framework throughout all the care we do. And so we screen for safety at every clinical interaction we have. We know how big of a problem this is in our country today, which is why we take it seriously and we ask the question at every visit. If you don't ask, you don't know. And so what that enables us to do is identify when risks are there and then put the appropriate safety protocols and mechanisms in place, whether that's creating a safety plan, engaging the resources in that person's life, whether that's a family member, a trusted friend, an ally to be their support system, or sometimes maybe that's getting them to a safe place if the thoughts are high risk enough. And so it's really important to us that we're always asking these questions and we're continually asking them, because just because you don't have those thoughts 2 months ago doesn't mean that they couldn't happen today. And we want to destigmatize having these types of thoughts to say, it's okay. We're going to work with you. We know it's scary when it happens, but there's a way through. And so this is one of the things that's really important to us here at Brave. And finally, how does this all work? It's really simple, right? To make referrals to Brave Health. What we do is we have an online form. Anybody can fill it out, whether it's you, a patient yourself, you're a healthcare worker at another facility, you're a family member. You go online, you fill out the form, and that kicks off the process of us getting in touch with the person who's seeking services. And it's really that simple. At the bottom, you see some of the links here. It's also easily available on our website. And I know Jenna just dropped that in the chat as well for y'all. And so these are some of the frequently asked questions, and we'll of course kind of go through this and have a Q&A here at the end as well, so you can ask us some questions. But this is just some of the other things about Brave that kind of stick out. I'll mention just a few of them really quickly. One is we're in network with almost every commercial Medicaid and Medicare plan in the markets that we're in. We aim to have availability within 7 days because we know how important it is to get care when you need it, not 3 months from when you need it. Like I was mentioning, we're 13 and up, and our technology requirements are just needing some type of device with a stable Wi-Fi connection. And I will pass it off now to Dr. Bisaga to talk a little bit about what they're all doing at Ophelia and how we're going to partner together to help some of our patients um, who need this types of support that we both offer.
Thank you. Thank you, Dr. Parikh. I think this, as you will see, I think there is a lot to say about the complementary nature of our the treatments that we provide. I think we focus primarily on the medical model, on this very specialized treatment of this most severe of psychiatric disorders, with the highest lethality rate. But we're a medical group, so we provide primarily medical treatment. And I think Brave Health can offer all the additional psychosocial behavioral services that often patients need and have difficulty finding in their community. We no longer have to worry about being a local care. We can offer it remotely. And I think this really is a very nice complement. So I'm going to briefly tell you about Ophelia Health, because again, many people wonder, how can you treat such a severe psychiatric disorder via telehealth? Is it safe? Is it effective? So this is very brief outline of us. So we are, obviously you're all aware about the public health emergency, the only one right now that we are in the middle, with many people dying of untreated opioid use disorder, primarily because there is lack of in-person quality evidence-based local care. And this is what continued for 20 years. And that's what led to deaths of close to 1 million people, mostly young adults who otherwise would have had many, many years of life ahead of them. So we're founded in 2019. Zach Gray, who had lost his girlfriend to opioid overdose because she wasn't able to find stable access to treatment. And myself and my colleague, Dr. Williams, we've been in academia. We're full-time faculty at a major university, also work with international agencies to try to develop effective treatments and disseminate them in practice. And so we paired up in 2019 to create solution to this problem, right? To have an effective, accessible treatment available to everybody who needs it, primarily to patients who need it the most and have greatest difficulty accessing, which is Medicaid population, right? So what we are a virtual medical group that we specialize in treating opioid use disorder. We also treat comorbid kind of common psychiatric conditions and other substance use disorder. And we primarily use medication and medical counseling. We don't have many. We have few psychiatric providers. I'm an addiction psychiatrist, but most of our clinicians are not psychiatrically trained. Nevertheless, they can still provide very effective treatment. Most of our patients use insurance. We're now active in 14 states and growing. We've treated more than 20,000 patients. So we have a lot of experience of how deliver this care and answer or solve some of the challenges that healthcare system is facing, and which is one of the reasons for all the deaths that I discussed. So as Dr. Parikh was saying, there is so many barriers to accessing care that many people who may even be interested in reaching out give up very quickly, right? Because of the geographic difficulties, because of the highly stigmatized condition as opioid use disorder is, and need for a private treatment. As you know, small towns, there's only one treatment provider in town, and you clearly will be very uncomfortable having this care that everybody knows about. Obviously, access to quality care that can be affordable is a problem. So if you can offer insurance, I think many people will access it. Many patients have experience in treatment programs, in traditional programs, which were traditionally very punitive, at very narrow set of goals, were very eager to discharge patients for non-adherence or for struggling in care. So we have this model that embraces many treatment goals, including harm reduction goals, recovery goals, and uses in a patient-centered, non-punitive manner. Again, we can allow patients access care within days. Certainly, most of patients can initiate treatment within less than a week. and stabilize on medications, often again within 2 to 3 days. We offer access to care on nights and weekends, so people who have work, who have childcare obligations can easily find time that they can access care. And again, because it's from the comfort of their home without need to travel, whether in the evening, the weekends, or during lunch breaks, it is very easy to access care. We, again, treat is a patient-centered care. We treat everybody as individual and tailor care they receive to their needs. We use evidence-based effective medications, primarily buprenorphine, either daily or injectable, and we're thinking into expanding to other medications. We have developed a lot of specialized protocols that will allow patients easy initiation of the buprenorphine. So we were able to overcome many challenges that providers have, mostly because we have a power of the scale, right? We have 60 clinicians who have treated and initiated thousands of patients. We are learning from this experience. We have a care team that helps solve pharmacy challenges. As you know, another barrier is that pharmacists may stigmatize patients, may not carry the medication, may treat patients in a way that does not really does not feel good. And we're trying to help patients solve these challenges try to kind of change all the misunderstandings with the outreach in education. We also solve barriers to clinicians. So a lot of clinicians who may even wanted to treat these patients populations usually cannot find a space to do that. As you know, many clinicians, when they work in traditional settings, have a lot of patients, are at risk of burnouts, and have to deal with a lot of administrative barriers. And we have designed EHR from ground up for our clinicians. The first few clinicians, we sat together and designed the EHR that suits their needs and their patient population, rather than adapting some other EHR. With obviously all the administrative responsibilities are taken away from clinicians who only focus on seeing the patients and writing a clinical note and communicating with other team members. We have very extensive training for clinicians with the shadowing program. So when they see these patients who sometimes may be complicated, they feel confident to do that. We also actually use this shadowing system to train. So we are actually training all nurse practitioners who are in Penn or Yale NP program to have opportunity to have rotation with us. We have psychiatrists, myself and my colleague, who are able to provide, if needed, supervision of more complicated cases. And we have a very strong academic, looks like Brave is very similar, academic interest in training our providers. We have grant runs, and we have also, I think, very vibrant community, which makes it very attractive to clinicians. We rarely lose clinicians. Most of clinicians are glad and happy to stay with us for years and expand even hours they work with us. But we also have ability for part-time clinicians to work with us. So can telemedicine treat this very severe condition? So we were very reluctant to do that, but then the pandemic came and we had no choice but to switch to telehealth, right? Everybody switched to telehealth because there was no other way to do treatment. And we were able, some of the regulations that made it difficult to do it via telehealth were lifted temporarily. And we have actually, the telehealth evolved over this past 5 years, right? And now we have research supporting that effectiveness of treatment via telehealth is similar, if not greater, than traditional in-person treatment programs, usually as shown by improved retention in care. And obviously, the longer patients stay in care on medication, the more they're protected from overdose, and the more they are able to focus on developing their skills and their journey towards recovery. Also, being able to be very flexible, nimble, and we are able to implement very rapidly this modern approach to MOUD, which was necessary when fentanyl dominated the illicit opioid use. This was a very different addiction than with heroin. We had to change many protocols, many treatment goals and framework of care, and we were able to do it very rapidly to create, again, this patient-centered, inclusive, non-stigmatizing care with harm reduction goals. So again, allowing patients who have interest in decreasing harms, decreasing use, to find a provider who will work with them towards these goals, with the hope that over time they can move towards more encompassing treatment gains. Again, this flexibility, being remote, not having such a frequent urine drug testing or not having in-person assessments, didn't really increase the risk of this treatment, and likely led to decrease in overdose deaths because more people were retaining care. Most importantly, patients are satisfied. The cost is much lower for patients and for providers, and of course, access is almost like there is no barrier. We can reach everybody, and I'll show you briefly later the map. We also benefited from technological advances, right? So this kind of consumer-driven healthcare that developed during the pandemic, we were able to learn from other companies that have done it and made treatment very attractive to patients. And finally, a lot of our patients come from being directly targeted, directly advertised to. So we call it direct-to-consumer advertising. So those are patients who have not been in touch with healthcare system, haven't had overdose, haven't been in the emergency room, hospital. Many of them are in the earlier stages of OUD. Those patients are usually invisible to traditional addiction care. They're even invisible to primary care, but we are able to find them and engage them in care. So what is the model we provide? I think it's very difficult to what Dr. Parikh was saying, that we provide a range of clinical services. In this case, is medication and medical counseling. We also do psychopharm and kind of more commonly co-caring, maybe not as severe psychiatric conditions we are treating, because often patients don't have way to find providers locally to treat that. We're glad that Brave Care partners with us, so we can now have a go-to person to refer those patients to. But we often treat psych conditions because patients have nowhere to go. We provide treatment for everybody gets treated for tobacco cessation. And we also develop protocols to treat now patients with co-occurring stimulant use and opiate use. So methamphetamine users, we use some of the evidence-based medications to treat them. We're very flexible, 7 days availability. We use urine drug testing as clinically indicated, not because we don't have to do frequent drug testing because we needed to medicate for that. We are able to offer UDS only as clinically indicated, which increases satisfaction. We treat many patients, and actually we can access many more women that can be accessed in traditional care because, again, of all the barriers that you can probably imagine. And again, we have team bear case model, so each patient gets 2 primary clinicians, get a nurse, get a care coordinator, have a supervising clinician. So there is a big team that thinks and works with each patient when needed. And again, we also are screening for social determinants of health and try to address them. If not ourselves, then definitely link them to services in the community. So I can see how we can fit in the treatment ecosystem that I understand you guys on this call are part of this. And there was a huge treatment gap for specialty OUD care. And I think we're just trying to fill this gap by offering. And again, because it's telehealth, we can actually see patients much more frequently than traditionally, right? So on average, we have 75 touch points. Many of them are text messages, but some of videos, which is essential when patients undergo detox, undergo buprenorphine induction, have to stabilize. I think we can reach many more patients much more often than traditionally. So what are our outcomes? Just to say that we treated over 20,000 patients. Most of the patients, 83% use insurance, 76% of those are Medicaid, 70% patients were not previously in treatment, which I think is really huge. 50% of patients don't have primary care providers. And when you look at what are our outcomes, so the traditional HEDIS, healthcare utilization measures, treatment engagement, so 2 visits in the first 35 days, we can retain 77% of patients as compared to national average of 30%. And at 6 months rotation, depending on which populations you meet, but when you put them all together, insured and self-pay, it's about 64% compared with the 28% national average. This is just one of the papers that we've published that shows the top line is the retention in care at 180 days. 100% are all people retained. As you see over time, patients do drop out of care for a variety of reasons. But so our sample that we've looked at here, again, 70% are still in care at 180 days. And this is a comparable groups from Medicaid and Medicare insurers. So as you see, we can double retention of care even in this very simple measure. Again, most patients do get UDS. We published paper on that. Most patients who get tested are positive for buprenorphine, which is they do not divert medication, or at least they're taking as prescribed, or taking, maybe not as prescribed, but certainly they are taking, and very few people are positive for other opioids. We also look at other measurements based of care, measures of anxiety, measures of depression. This is a measure of recovery, BARC, which is a set of 10 questions that measures internal and external resources that can help people initiate and retain recovery. And most patients who come with low recovery capital get improved over time, actually very quickly. And most patients who come are already at high level of recovery capital stay in care. This is the poster we just showed last month at ASAM. We are able to reach many patients. So you see Pennsylvania and New York. Red is where our patients are, but there is no MAT provider. So traditional, the kind of old way of looking at where treatments are. So providers would be waiver. Blue is the provider and our patients. As you see, there are huge treatment deserts, and we're able, with the blue marks, fill at least some of them in both PA and New York, which are our key states. Patients spontaneously report their treatment experience. We encourage them to post their reviews, because I think nothing like direct hearing from patients that can convince people who look for care. We consistently get 5-star ratings. I looked this morning, we have 1,564 reviews. Most of them are positive. I think it's very good. If you want to get a feel for what's like to be patients with us, I think it's a good way to look at that. And obviously our Net Promoter Score are much higher than most of healthcare industry or average healthcare industry providers, as expected. So let me stop here, because I want to make sure that I give time to Erica, who's our Director of Education and one of our stellar clinicians, that can maybe tell you about a little bit like what's like to meet patients in keratophilia and how is it different from more traditional settings.
Hi, everybody. My name is Erica. I am our Director of Education, but I'm also a clinician at Ophelia. My background's mostly in FQHC land, and I still have my toe in that per diem. And so I have a lot of, different setting experience, but working with our patients at Ophelia is pretty amazing. We truly are able, through telehealth, to meet people where they're at, not just figuratively, but literally. We see people coming from work, coming from home with their full family. People are able to access and stay in care in a way that they were never able to before. And those statistics, our data really shows that. But I also feel it on the clinical end. I've been with Ophelia for about 4 years, and I still see the same patients, and they're just doing great. And a lot of my patients have never had the experience of consistent, quality, thoughtful care where they got to feel like their condition and their problems were actually treatable with dignity and respect, and in a way that's available and accessible to them. And we hear that constantly from our patients. And it's such a pleasure to get to offer that to our patient population. And I see people in cities and super rural areas, just all over. And that access is really amazing for folks. And in a lot of cases, it really is life-saving and also just life-changing. People really get to make the positive changes that they want in their life. And my primary care brain is always very excited, because a lot of our patients then are able to take care of a lot of other healthcare things, whether it's taking care of their mental health diagnosis that's never been treated or managed, or getting back into primary care, doing some preventative screenings, things that are just going to make a long-term difference in their healthcare and health outcomes and in their life. I think I'll leave it at that. I want to make sure we have time for questions and if people have thoughts, but Ashley, I'll let you guide the next steps.
Thank you so much. I've certainly learned a number of things on this part of this webinar, so I really appreciate all of you for sharing your expertise and also your personal experience treating patients. And so I have a number of questions, and I'm just going to start the first one really with whoever wants to answer for me, the Brave or Ophelia. And really, I'd love to hear why this partnership matters for Medicaid patients in particular. How can this really be transformative for them?
Before we start answering, I just want to make sure that I introduce Emily Bihar, who is on the screen as me, but it's only because she clicked my link. But she's been with Ophelia also for 5 years almost in many roles, and she's now heading the partnerships. And I think she and Dr. Parikh can answer these questions. But I want to make sure that I put Emily here on the map.
Thanks. Nice to see everyone. I also realized I was writing in the comment section. So Adam, it looked like you were both presenting and able to write into the chats at the same time.
I was very impressed by that, Adam, both Adams. Yeah, Emily, you were would love to hear from you why this partnership is important. You've been really instrumental in it.
Yeah, I think, one thing that I'm sure is not new to all of us here that have worked with this patient population is that it is often the case that the patient has to be their own advocate, the patient has to be their own care navigator, they have to be the one person that is in charge of their own care. And we know that it's a very fragmented system, and that is a tremendous strain and challenge for any individual to handle, especially when you are in the throes of managing a substance use disorder and, co-occurring mental health conditions. So I think one of the things that really I take very much as our responsibility is to be able to create the integrated systems for our patients so they don't have to do as much of that work themselves. And I think being able to have partners that we trust, that we know align philosophically in terms of how to approach patients in a non-stigmatizing way, how to provide really high quality evidence-based care is really important, because patients don't know how to necessarily make those evaluations. And it's a lot of work to do that and to coordinate it. And so for us to be able to have that system, and we can say to a patient, you can manage your OUD with Ophelia, you can manage some of the more severe psych conditions with Brave, is logistically a huge barrier removed, and then also just a much better experience. And it gets us closer to the goal of actually having whole person care that we know we, talk a lot about and want to be able to offer. But then we as clinicians can speak to each other about how the patient's doing. We can make sure that our treatment plans are aligned, that they're complementary. That's huge for patients. It's not an experience patients normally get.
Yeah. I'll just add to that also traditionally patients with Medicaid are often not given flexible, patient-centered offerings in the healthcare setting. And my patients are consistently blown away that this is for them, that they have access to this type of care that is flexible, that is telehealth, that is really centered on their experience. And it's a really new and overdue feeling for a lot of my patients. And it's exciting to have options for them.
Yeah, I would echo what both Erica and Emily are saying here, in that, we see the whole person, right? Healing isn't just about one diagnosis, one prescription. It's about comprehensive, compassionate care that meets people where they are in their life, and kind of coming into their life rather than having them have to come into ours in an office setting. And what's really important to us was that we see too many other behavioral health groups who have restrictions on admitting patients to their services who are on medications like buprenorphine. We don't think that makes any sense, right? Like, there's nothing stopping us from working together rather than creating artificial barriers to care, which is what we really think happens sometimes. And so our whole goal is to reduce all those barriers, reduce all the friction points, work together as a team, so that some of the most vulnerable and underserved populations that we're talking about here can get the care they need. It's pretty simple, I think, if you just break it down.
That's great. Thank you all for sharing that on that. I hope that it's a partnership that can really change many people's lives. Um, I'm wondering what you've talked a little, but all of you have talked a little bit about, partnering and not needing to work into silos. I'm curious what you think the future could hold for more organizations like ours coming together. Are there other parts of behavioral health care, and particularly in the addiction treatment front, that need more collaboration?
Yeah, I think what we need more of is what we're doing here first, right? Like I think like this is a step in the right direction. It's about like, okay, let's work together. More broadly speaking, though, the mental model that I kind of use here is that, at Brave Health, we do a lot of different types of care, but there are specialty services within psychiatry and behavioral health that sometimes we don't offer in-house. And for Ophelia, that's medication assisted treatment for opioid use disorder. That's not something we do. But just because we don't do it doesn't mean that there aren't awesome teams doing it out there. And so while we see a broad swath of different types of diagnoses and support patients in a lot of different ways, there are times when we identify, hey, you need something from a specialist, a behavioral health specialist. And that's where we can really tap into this growing network of companies that are providing these like highly specialized services. And what I'm finding extremely exciting is that a lot of these services historically have been limited to areas where access to healthcare is good, right? In larger cities and places that have large systems to provide that type of care. But we're all breaking that mold by doing a lot of this virtually and saying, well, look, what we're really doing is leaving out broad swaths of more rural populations who need that specialist level of care, but just don't have access to it in their local community, and sometimes would have to drive 1, 2, or 3 hours away, which makes no sense. And so that's what I'm excited about, or what I see moving forward.
Yeah, this is where I also think that telehealth is not just brick and mortar care that happens to be done over video. It's a really different type of care, and it requires us to interact differently with each other, which is why I'm really glad that you guys are also on the call for this, because I think, everyone now has access to a specialist, and that's amazing. Like if you live in a traditional treatment desert and all of a sudden now you have access to a national expert on OUD or on, psychiatric conditions, that's amazing. It doesn't work if all of a sudden you have access to 20 different experts and those experts aren't talking to each other, and then it becomes, really complicated to manage, which is why part of really doing telehealth care really, really well, it's not just about the care we provide, it's about making sure that we're doing the work to be that partner. And that's not just us and Brave, it's also you guys on the call, and it's care managers that are managing patients, and it's the PCPs. So it really is a group effort. And I think if we can get ourselves working together, then the outcomes will be just so far superior to anything that patients have experienced before.
Definitely. It's also much better from the clinician's experience, right? It's much easier if I'm working with a patient really stable with their OUD, but they're really struggling with some more severe mental health or mental illness, and I want to refer them. I love getting to have that conversation and refer them to a place where I know they're going to be treated well, where the service is good, where I feel really good about that referral and that collaboration, and that you know, the clinician at Brave is going to collaborate with me and treat my patient well. It's just seamless and such a better experience for the clinician, for the patient, and then the outcomes are also usually much, much better. Yeah.
Thank you both. I want to make sure that we have time for people who are joining us to ask questions. So I'm going to scroll up in the chat and see if there are any that have been unanswered. And now would also be a great time if someone wants to come off mute and ask a question. Please feel free to do so.
I'm happy to answer that last question, which we didn't answer in the chat yet, maybe while other people are thinking of additional questions. But there was a question about how the rate of patients at Ophelia that are not connected to care prior to joining us. We were pretty intentional when we started Ophelia to try and use marketing directly to patients as a way to engage them. You may hear like the invisible 80% is something that people often talk about, of the percent of patients with an OUD diagnosis that have not disclosed that diagnosis to their PCP or are not engaged in care around it. And so we figured, you know, if we start Ophelia only by building out referrals, then we're only actually treating the patients that have already, you know, spoken to somebody in the healthcare system about their diagnosis. And we know that there is a large group of patients that are really vulnerable, really high risk, that are not talking to anybody about their use. And so we really wanted to make sure that we were bringing them in. And then, as Erica said, once they're stable with their OUD, all of a sudden, and once they have an experience where they trust someone in the healthcare system, all of a sudden we can connect them to care. We can get them to a case manager at the, at their payer. We can get them connected to primary care, dental work, whatever it is that they need at that point. So, by and large, we have really reached out to patients through generalized marketing.
Thank you for sharing that. I had no idea that was the reason why that you had such a strong following, and it makes so much sense. I love that.
So if I can just add that, of course, that there is a value in having a local providers, right? Every community would ideally have all the providers that people know each other personally and trust. And that's the model that we should all work towards. But often, if like big cities like New York City, where we are, you have a lot of providers or services offered to patients that those don't know about each other, right? So first, we would like to be local as well as we are national. We would like to have a relationship with local communities, and we have our community partners that do want to find out and learn about local services, and hopefully we can connect with you, and they can be in person, very kind of, I think, personal relationships. But we also would like to to be a hub for our patients, right? Like a health home for patients that, as Emily was saying, once they trust us, we can then tell them about all the services, and they will trust us that because we suggested, they will go there. So we can, like this web of all the providers, local and global, I mean national, you can see how we are trying. I think Brave is doing the same thing, and reach the traditional ecosystem with this kind of telehealth providers that can play these various roles.
Great. Well, this has been such a lively conversation, and I'm just thrilled that our organizations are going to be working more closely together. And I would imagine over the coming years and decades, we'll be surrounded with many others who are bringing behavioral health into the future where it belongs. Thanks everyone for joining. Have a great rest of the day.
Thanks so much.
Thank you.
Appreciate it.
Everybody.
Take care, everybody.
Thanks, everyone.
Bye.